We've had lots of different visions for general practice, from the blueprint to primary care, the 5-year forward view, the long term plan, the PCN DES. And how many of these have had genuine grassroots interaction? Well, in this episode, myself and Andy are going to review the blueprint for primary care, which is my review from way back when, back in 2005 or something, no, 2015 or something. And we're going to have a look at what that looks like now in comparison, and also what this potentially means for the future, including the opportunity for you to help us create a future blueprint for general practice from the grassroots. Let's crack on and take enhance your primary care and learning. Hello, GP Liz. We're going to get started, but how are we thinking there, Andy?
Yeah, I'm good. Thanks, Gandhi. Yeah, really looking forward to having a discussion on this topic with you. Viewers of the channel will probably remember that a few weeks ago, I looked at one of your old articles on the
Hmm.
eGPlearning website. Way back in 2015, you'd written an article proposing a blueprint for general practice.
Hmm.
Quite a nice, in-depth, well thought out article, actually. I think you perhaps had some collaborators at the time when that was written. But when I was doing the video, I really wish that you were there to talk about some of the concepts and ideas.
Hmm.
So now you are. So it'll be great to, in this video, review that document, but more importantly, then focus on first brainstorming some thoughts and ideas for a new blueprint for general practice in 2022, because gosh, the world's turned and things are very different since 2015.
Hmm.
And also to kickstart a process of creating perhaps a new crowdsourced, open source, a new blueprint where we can incorporate the views of other people, including the viewers out there, viewers and listeners of EGP Learning. So very
Yeah,
excited to
absolutely.
get that process started.
And I think if you do want to know how to do that, so we're going to go through this a bit more detail towards the end, but we've set up a method called using a website called SpeakPipe that Andy's just brought up on screen for you. And if you want to go to it, it's www.speakpipe.com/egplearning. And remember, the G and the P are capitals. And that allows you to basically do a recording with your phone or your computer. It doesn't really matter what. And that sends an audio comment back to us that we can then have a look at and stuff. We may even use it in future episodes. And just so you know, for future contact with us and you just want to send us a message and stuff, use it. We're more than happy to let you do that and stuff. It's really short, really easy to use, works on pretty much every platform going. Really low challenges in terms of using it and stuff. But have a look at that. But we're going to talk about right now what our blueprint was. So shall we have a look at the original way back when from 2015? Yeah, there we go. 23rd of May 2015 was when I wrote it. That was with Dr. John Cosgrove. It was a collaboration between myself and him. It blew up. It was crazy, honestly. It's the highest hit rate I've ever had on the eGPlearning website when that released. And I remember I was on holiday at the time, and my phone just would not stop buzzing with all the notifications of the number of hits and things that was going on. So back then, it was a massive thing for me, at the very least. Um, but there's been a lot of changes since then, and we need to recognise that. And Andy's review is amazing, so definitely go off and have a listen to that episode. But like you said, Andy, we're going to have a look at what that means now. So do you want to take us through it?
Yeah, and it's so great to have you here so that you can respond and be accountable for some of these things in the
Absolutely.
document, because I agreed with most of it, but and some things, to be honest, it mostly dates really well. But
Hmm.
let's just have a look and remind ourselves what's in the old
Hmm.
blueprint, because that's probably going to be the starting point for the new blueprint that we want to kind of co-create with the community out there. So let's see what's in that before we, in the later part of the video, brainstorm
Hmm.
some new ideas. So um, it's structured in terms of ideas, which I think is a nice way to do it. So idea one was produce continuously monitored activity levels of general practice, both demand and access. So what were you, why was that in there back then, Gandhi?
So I think back then that there was very little in terms of abilities for us to understand the element of demand and capacity in general practice, and I think that's one of the things that many people working in general practice often comment on, that the demand for general practice massively outstrips the capacity, but we've never had real evidence to help support or refute those potential claims. So I think having the ability to manage and understand that would be absolutely paramount. I think it's
Yeah.
interesting that we've seen some progression in some of that, and more than happy to talk about the options available. But I think it's one area that continues to need development, because actually you can't really adapt services to the demand if you don't know what the demand is.
Yeah, that's what I thought when I was reviewing. Really, we know a bit more about activity, and there's
Mhm,
lots of effort to count and measure activity. But the demand side still a little bit difficult to fully
mhm,
understand the demand. So that was an interesting one. Maybe that'll make the cut into the new blueprint. We will see. There was a call to increase the remuneration for and supply of GPs to enable them to have smaller practice lists and maintain the activity level. So I think really that's a call for more funding and a reflection that the funding for general
mhm.
practice perhaps doesn't reflect the job that it is asked to do. And I guess we're only being asked to do increasingly more going
Absolutely.
forwards. Bit of a no-brainer, that one, I think.
Mhm. Yeah, I mean, this
So,
is a repeated comment by many organizations involved in general practice that actually, back when we wrote this article, general practice only had 8% of the NHS funding and was being expected to do, it's commonly mentioned amount of 90% of the workload in general practice. Um, I know that there has been an increase in the amount of funding that general practice receives, and in particular, a lot of that over the past couple of years has been very much vaccination focused. So obviously, that funding will no longer be potentially applicable. And there's been some funding given to general practice in the form of the PCN which again is not direct to practices, but actually increasing the direct remuneration for practices to provide healthcare. If there's really good information out there that shows that general practice is really cost effective in terms of helping manage the healthcare system. So actually, logic would go that if you put more investment into it, it can perform better, and therefore that means that we have generally, hopefully, better health of our population, ge- better working environments, and all that kind of stuff. And hopefully, we'll see that because at the moment, for £150 a year, you get all unlimited healthcare access.
yeah, it's a good deal. And
Hmm.
these questions around funding. I mean, if they're not in the paper or the blueprint, then they're going to get neglected, aren't they? You have to say
Hmm.
something about funding and make the case for it and highlight the benefits of general practice.
Hmm.
Um, Idea 3, so you're breaking this down, but this was really about controlling activity was the
Hmm.
main theme here, which I think is, it's very sensible. And in some ways, at the moment, we have a bit of an unlimited activity sort of philosophy going on, don't we?
Hmm.
In general practice in the NHS in general, people can come with and about anything. Not everything's available,
Hmm.
but it's really, really open door. You'd raised some specific things here. I'm just wondering how these have stood the test of time, really. So only allow prescription only. Allow only the prescriptions of prescription only medication items on NHS prescriptions.
Hmm.
Okay, yeah. So no over the counter, basically.
Well, sort of. So, yeah, over-the-counter medications shouldn't be available on prescription. So, therefore, if you can get them over the counter, you get them over the counter. Not enabling that to be available on prescription. Now, there are definitely pros and cons to this particular aspect of things because there are certain medications that obviously have multiple uses and can be available over the counter for very specific uses, and therefore we often and can sometimes prescribe them for other reasons. There's also the element of health inequalities that actually prescribing medications means that those patients who can't afford to pay for them over the counter obviously then are able to have them for free because they get their free prescriptions and stuff. But it was an element of reducing demand. So one of the challenges you sometimes have is that you have patients attend for a prescription as part of the consultation because they could have it for free on prescription, and that's part of the reason for the attendance. So there's an element of looking at, is that going to help reduce activity and demand? So therefore, it's prioritized for other healthcare reasons and stuff. It's a controversial one, and it speaks to a lot of the content in this particular part about prescriptions, which is one of the key things.
Yeah, yeah, absolutely. I agree. I mean, I think we're getting better at this in general practice and in the NHS probably since this was written. But I do remember the consultations where somebody would come and have a 10-minute consultation with me, pretty high cost to the NHS, so that
Hmm.
they can get a prescription to get their paracetamol free, which they could buy for
Yep.
32p, those sorts of things. It was just really bizarre the way the incentives were set up. And I think that's really the thrust of this section, really, isn't it? It's talking about controlling activity with quite a focus on prescribing, I think, in this
Hmm.
section. I'm going to move
And
on.
if you just
Oh,
scroll back up, there's one part I did want to
yep.
cover, and this is probably one of the ones that I think really and will continuously needs to happen. Reevaluate the criteria for a free prescription, because actually free prescriptions hasn't been reviewed for a long period of time, and those patients eligible for free prescriptions and those that are not eligible for free prescriptions, it's just completely out of kilter with healthcare need. And it's an area that massively I feel needs reevaluating. Either you do in England what other areas of the developed countries and stuff have done, which is everything is for free in terms of prescriptions and stuff, because then you reduce that whole bureaucracy and element and management of that side of things, or you reevaluate the health criterias that are available for free. And the one that always boggles me is asthma and COPD. If you have that as a chronic lung, health condition, you're not able to have those prescriptions for free for having those health conditions, and that just makes me, really frustrated, because those are the patients that have real health risks in terms of, deterioration, ending up in hospital because they don't have their medications, and then that leads to admission, which is a high cost to the NHS over the cost of their potential prescriptions and stuff. So, and then the other one that really confuses me is that if you've got hypothyroid disease where you need thyroxine, yes, absolutely, you need to have that on a regular basis, so that should be free. But then just by having that, you get every single prescription available for free in comparison to patients with COPD and asthma, which don't.
Yeah,
It's just, yeah, it
yeah,
annoys
it's
me,
bizarre.
frustrating. Yeah,
Yeah, definitely fertile ground for looking at that. There's a lot in this document,
Mhm.
so forbid priority to be given on the basis of a referral from NHS staff for other services or treatment not agreed with the GPC. What were you driving at there, Gandhi?
So I think this was the basis of, trying to understand how referrals work, the concept that everything has to go back to the GP for their referral, and that, everything has to go through this one point, and therefore that's how the healthcare system has to run. Now, this speaks to an element of the gatekeeper role that general practice has. Um, but it seems to be that, if a GP gives a referral, that seems to change things. And actually, why should that be any different to any other member of the healthcare service? If there's a need identified by a healthcare professional, and they are competent and able to make that assessment, which they often have, then that shouldn't change things and stuff. So why does that happen? And that kind of leads into the other points coming down later on and
Mm.
stuff.
Yeah, these next two. So this was getting a little bit controversial.
Mhm,
I thought. So you're talking about contracts separately for medical treatment of those with no illness. Essentially, what I thought you were driving at here was really sort of all of those additional sort of prevention roles, or treatment
mhm,
of cosmetic issues. It's difficult to know where you draw the line here, but that those should be contracted separately, which I think was quite a big ask, a big suggestion, and we've only gone in the
yeah,
opposite direction here, really,
mhm,
with more talk about prevention and so forth, and population health. Although
sure.
maybe that is contracted separately, because a lot of that is being put within the primary care network, DES, and the activity of primary care networks. So,
Mhm.
um, how do you think this is aged, and do you think some of this is actually being put into practice, Gandhi?
So I think in particular 3.3, which was the forbid advising people to consult their GP except if they were ill, believe themselves to be unwell, or for any reason agreed by the GPC. This again was very much from other healthcare professionals directing people to go see their GP for whatever reason, when there wasn't an actual medical reason for that happening, but also the concept of many of the private companies doing random tests and that kind of stuff, and making significant profits from doing investigations on patients, and then saying, well, we're not going to deal with the outcomes of that. You need to go see your GP for everything, because we're not going to take any responsibility for the stuff we've done, whether that has any relevance to the health of that patient or not. And that's where it came by agreed by the GPC, because there are elements of that that absolutely should be looked at and things, when there's a healthcare need and identified elements and stuff. And then, as you mentioned, that health promotion side of things, actually, should that be contracted separately outside of general practice provision, in terms of, is general practice actually a public health engine or not? And I think that's where, like you mentioned, that the lines have become a lot more blurred since the PCN-DES has come around, because there's massive, huge elements of that. There's about health promotion and keeping people, and preventing disease, sorry. So that's started to happen in some ways, but is it the same thing? Interesting to hear people's perspectives. And again, if you want to give us those perspectives, jump over to SpeakPipe. So that's speakpipe.com/eGPlearning, capital G, capital P, and give us your thoughts. live so we can hear them.
Yeah. So next, I think we were trying to reduce the home visiting load essentially
Mhm.
with this, or the inappropriate requests for home visits, which are really really difficult to handle, and the
Mhm.
amount of resources that go into visiting someone in their home, as opposed to them coming to the surgery, are huge. Do you think this has got better? I just by the by, are you guys doing more or fewer home visits in sort of post COVID? Because I think we're probably
I
doing less inappropriate ones. I
Yeah.
think we're still doing them, but
I think the concept of remote triage and remote consultations has massively reduced the number of inappropriate visits. I think there's still an element of the historic elements of general practice and AKA Dr. Foster popping around to come and see, patients on every single, contact and things. Healthcare is different. It is no longer that historic elements of the GP being able to go around and visit every single patient in a home visit and stuff. And then, some of the I still get some of those comments from patients, "Why can't you come and visit me?" Well, you've just been to the hairdressers, so, if you are well enough to do that, you are well enough to come to the practice and not need a visit. A visit is a finite resource, and that's one of the key words that I would put in there. And there is existing guidance out there to help practices and stuff in that. I think that it's one thing I've been very strong, and a lot of my trainees know about this. That if you're visiting a patient, it should be for the right reason because that impacts the amount of capacity you have to deliver healthcare to other people. That takes away services from other people because of the time you spent to do that. And there are absolutely times visits are important and relevant, but it's a finite resource.
yeah, and the quality of the assessment people get is superior at the surgery. This is the point I
Absolutely.
always make. The couch, the lighting, the equipment. If we need to do an emergency ECG, we can do one. If we
Mhm.
really need to fire off some blood tests, we can do them and make sure that they're collected and stored and processed appropriately. So much better. We have the medical records immediately to hand.
Mhm.
Um,
And
much
relevant
better.
examinations. There are certain examinations that are not appropriate to do in the
Yeah.
home environment, for safety reasons, for dignity reasons, and that kind of stuff. The level of assessment we can do in an established practice environment is far superior to the amount that you can do in the home environment. But again, there are absolutely times where a home visit is the best way to deliver healthcare, but it should not be a right, I think is the key thing. We were, a demandable right. It should be a resource to be used effectively and sensibly.
Yeah, and 3.6, remove fitness certificates from the
Yeah.
GP role. I mean, this sounds like it would be very helpful. There are some strange sort of in in it's a difficult relationship, isn't it, with patients when it
Mhm,
comes to involve their need to work and contribute to society and so forth. Um, and I think none of us have difficulty providing sick notes for sort of legitimate things, but there's a grey area, isn't there, where
mhm,
really people might be encouraged to work, but they might not take that very well, and going down that
mhm,
road with the patient might damage the relationship we have with them, which might
mhm,
reduce how effectively you can act as their doctor because it might undermine trust and so forth. So it's a difficult one, and so I totally understand why this is there in terms of thinking maybe the family doctor is not the right person to pass judgment on
mhm.
something that might be a difficult conversation for that individual, such as their ability to work. Totally agree. I don't think it's
Well,
too
it's
controversial.
interesting, there may be some shift on this one. So at the moment, it's still only doctors are the only people that can sign Med3s. Important word is doctors, not GPs. So our hospital
Mhm.
colleagues can and should sign a Med3 when they've advised that patient to no longer be working for whatever health reason that may be, whether it's an acute admission, outpatients, that kind of stuff. Emphasize that they should be doing that. That should not be transferred to the general practitioner. But there is some movement from what we're hearing that other roles will be enabled to do medical certification from sickness. But one of the really interesting things that happened, obviously, because of a result of COVID and the vaccination schemes, temporarily there was an extension of the self certification period from 7 days to 28 days, and it got reverted back to the normal 7 days, which actually a lot of people would suspect that did that really need to happen? Should we review the whole self-certification process and actually the involvement of occupational health in managing patients short and longer term in terms of absences from work? Because it's a specialist area. Actually, GPs are not specifically trained in occupational health. So particularly for longer term absences from work, like you mentioned, is the GP the best person to make that assessment when we've not officially and incorporatedly had training in occupational health aspects, particularly from a chronic perspective?
Mm. I think the role still lies with us because of resource issues. I think there are better ways to
That's
manage
the key
sick
thing,
notes,
isn't it? Yeah.
um, but all of these ways would add cost, and potentially sort of friction to the process of people getting sick notes, which is something
Mhm.
that their employers sort of need to kind of operate and justify their absence from work and access statutory sick pay and so forth. But yeah, the whole area I think
Mhm.
needs looking at. Idea four. So this is moving to a different area now. Um, and you were suggesting instead of capitation based funding, per head per population per year, which is the way we're currently funded, regardless of how often someone comes to the GP, there's just a fixed payment. There was a suggestion to move to activity based
Mhm.
funding, so perhaps a payment by appointment or payment by individual type of appointment or activity mechanism. That would be a huge change for general
Absolutely.
practice. It would shift the burden of managing increased and increasing and fluctuating activity from GP partners and GP practices to the commissioners and ultimately to the government, um, giving probably much more predictable
Mhm.
sort of financial models to practices.
Mhm.
A lot of hospitals have and currently run more in this method, being paid per operation, per procedure, and so forth. Um, this would be really, really expensive, probably, for the government. I'm not sure there's going to be appetite from the government to accept
Yeah.
the burden or the risk of fluctuating and increasing and changing activity. Um, but I think it would absolutely help the general practice sector better meet the expectation. Would it help people meet the expectations of patients? I don't know. I'm rambling, Gandhi. The
Mhm.
only problem here is that it might not be affordable. It might not actually be workable.
Well, I think there's 2 parts to this as well. So, like you said, there's a question of whether this is logistically even possible from a finance perspective, from a putting the systems in place perspective, because this would be one of the biggest cultural shifts that happens in general practice, moving from a capitation-based system to a payment by activity, because everything then is determined. General practice, like every other business, and let's remind people, general practice is a business, is determined on how it's funded. And if you shift to a activity based model, that changes the way that everything is done as a result of it, and that would be a cultural shift across the NHS, to be honest. And it would be one that I think would absolutely have a better understanding of capacity and demand. So it would help in terms of workforce retention, recruitment, activity, all that kind of stuff. But as you said, I think this is always gonna be in the too difficult to do pile. Does that mean we shouldn't look at it? Absolutely not. But I think it does spoke the whole concept that this needs a discussion at points, and that's why it was put in there and stuff.
Mm. It's a good talking point.
Mhm.
I mean, actually, the effect of getting rid of GP partnership and traditional contracting and having a salaried workforce, which is what some people
Mhm.
advocate or feel is what people and GPs may want going
Mhm.
forwards, would sort of have this effect, wouldn't it?
It
Because
would.
it would actually remove individual GPs from that role of being responsible for managing demand. The practices might do, or whoever owns and runs and has ownership of the responsibility of the practices, but that would be sort of NHS managers, wouldn't it? And trusts
It
and
would.
other organisations rather than individual GPs. So that might be a way that it's possible, but that might not be what everybody wants because then you lose a lot of that control that you have over how you work from being a partner. But
As you
interesting.
mentioned, so Sajid Javid's recent paper that he meant, I can't remember what it was called, your something or other, with, the think tank. We covered it in a recent episode.
Yeah.
Apologies, I've forgotten the
At
name.
your service,
At
I
your
believe
service,
is what
that
it's
was it.
called.
Yeah, yeah, yeah. So that mentioned about creating a salary-based service, and like you said, by doing that, actually, are you creating the byproduct of a payment by activity because you move the workforce to a model that is then has much more employment protection in terms of saying that actually we're stopping now, and we've done what we should be doing, what we're paid to do, and therefore we're not doing anything more. That obviously has a massive implication on whether or not practices would still be able to deliver the level of capacity and demand that's there. It also raises the question of, by not doing that, are we not just continuing with the whole chaotic system that we currently have, where partners and practices are basically soaking up the excess demand unfunded, and that's why we're leading to workforce retention issues and all the other kind of stuff that we talked about.
Yeah, maybe the loss of the partnership model is the price that would be needed to be paid to move to a payment by activity for individual GPs as employees model. Maybe that's the only way to achieve something like what you're asking for.
Hmm.
It's a big price to pay for a lot of people. Um, Crown
Ideas time.
indemnity, Crown indemnity for GPs. So you put a big tick in that. Thanks for raising that issue with the government, Gandhi and John
Yay!
Cosgrove. I don't know whether it was you guys that made it happen, but that's actually been a big positive change, I think, for general practice, and I think it's widely accepted to be really positive. So yeah, and it
Just
was
for those
called
that
for,
don't
yeah.
know what that means, so that effectively meant that GPs are covered under a similar model as hospital doctors have been for many, many years in terms of what's called the CNSGP. I've forgotten what it stands for, but it's basically the equivalent of Crown indemnity. And the reason why this was relevant back at the time that we wrote this, indemnity costs for GPs to work, so coverage that you had to have in order to be able to work, in some cases were going up to £20,000 a year. So they were having, that was coming off their pay before they'd even done anything and stuff, and that was not sustainable. Crown indemnity, because the responsibility that moves to the government in a sense, has reduced that significantly, which has obviously meant that we can now have more people working, which is always a positive.
Yes, that's positive. So big tick in that one.
Mhm.
I think this was calling for GPs to be recognised as a speciality on the same level as sort of
Mhm.
hospital consultants are specialists on the GMC register. And I can never really understand why that's not necessary. I mean, we are the equivalent of sort of
Yeah.
generalist consultants in the community. And I think the recognition of that would help with recruitment into the speciality and so forth. So that feels again like a no-brainer, and I never quite understand why it's not happening.
I think one of the arguments they've said is that they wanted a separate system so that people who are appropriately trained in general practice work in general practice, and not vice versa. So, for example, you don't really want your GP who's never done an appendix operation to be doing your appendix operation. Similarly, you wouldn't want a surgeon who's never dealt with general practice work in terms of dermatology and that kind of stuff working as your GP, because they may not be appropriately competent and trained to manage that. And I think that perspective that anybody could be a GP is actually incorrect. Anybody with the right training and approach and stuff can be a GP, but you can't just be a GP just because you're a doctor, kind of thing. It's not the same principle. And competency plays into this. So, yeah, actually, potentially aligning the two registers would make hopefully some element of perspective from people that GPs, quite rightly, are the equivalent of consultants in hospital.
Hmm. Good. Here. So exclude general practice from the NHS, a severe idea with growing support. So, do you still believe this, Gandhi? Or
So for clarification, just because we wrote this doesn't mean that we believe everything that we
of course.
wrote. But it's one of those things that to be considered. This is the nuclear option: remove general practice from the NHS itself, make general practice do what has happened to opticians, that's happened to dentists,
Mm,
in terms of removing them from the NHS. And we're seeing increasingly challenges with this. So increasingly more and more dentists, for example, are leaving NHS contracts because the NHS contracts just do not supply them with enough funding and resources in order to continue working effectively, which is why finding an NHS dentist is now almost impossible. But that's down to the contractual funding and elements of it. Actually, if we're saying general practice is so bad, do we need to remove general practice from the NHS itself? That has logistical and absolute challenges, but actually we're seeing the increase of private general practice. Babylon and some of the tech companies initiated this before COVID came along, and a lot of them have been hampered by, I guess, in their business plans because of COVID. Because actually, almost every practice across the country is now delivering remote care as well. But actually, we know many more patients are starting to use private healthcare services because general practice is just so overloaded. Uh, they just don't have the capacity, and therefore that's why people are going to private healthcare. So, is the other option go private?
it's a nuclear option, isn't it? I think this would
It is.
be awful for health inequalities.
Absolutely.
Absolutely dreadful. Because I can see how this might work in certain areas of our city in Nottingham, and you might have a sustainable business which allowed GPs to continue to operate in much the way that they do now, and those people would be paying presumably less tax, and they'd have some, they'd use some of that money or their existing disposable income to pay for health services with their GP.
Mhm.
But in other areas, more deprived areas, I just don't think there's that level of affordability there, and they would just get worse care in the way they probably get worse, dentistry input, and so forth,
Mhm.
and services that
And
aren't as
examples like
responsive
that
as
are in
those.
America. Many people comment about the amazingness of American healthcare, but also it's one recognized as one of the worst for health inequalities across their populations, where many people do not have access to healthcare. Many people do not have access to the medications they need. Many people do not have access to appropriate treatments and stuff because they just simply cannot afford it. And medical bankruptcy is a thing in America. It is not really a thing in the UK. Provision is the different aspect of it, though.
Yeah, absolutely. Sometimes you need to sort of spell out what is at stake, don't you, in order for people to take things seriously and appreciate, what is there and what they have and what they have access to.
Mhm,
So I thought it was quite good that that was there. Actually, it's an
mhm.
option, and really this blueprint sort of serves as a bit of an options paper in the way it's written. So I thought that was great. So that was then. We're now moving into 2022. So
And
the
just before
objective
we
here.
do that, if you
Oh,
did
go on,
wanna give
Gandhi.
us a yeah, no, just before you if you did wanna give us your comments on the existing points that we made in the further blueprint, then absolutely, again, just head over to www.speakpipe.com/eGPlearning, capital G, capital P, and we will be able to hear your comments and thoughts on this. Ultimately, stick it in the chat down below because we would love to know your thoughts and this stuff on this particular episode. But we're moving forward with some changes that Andy made to my blueprint and stuff, so tell us about it, Andy.
Yeah, well, so I made some suggestions in the video, but I thought we could build on that and go a little bit further, really, and start to just have a little bit of a brief brainstorm in front of everybody else about sort of uh, issues or points or suggestions or ideas that might go into a new blueprint for 2022, just to stimulate people's comments really and suggestions. And I've had some thoughts. I'm really interested to know what you sort of think going forwards. My mind works often in quite a sort of systematic,
Mhm,
thematic way. So I think there are some areas that a credible paper needs to touch on in order to be effective. So I'd break it down in that way, really. I think first of all, you have a foreword, or you set the scene, and you get an influential person to write it. So if we were doing that from EGP
this is the
Learning, we
health
might try
secretary.
find someone to write it. Maybe Savage Javid won't do it for us,
No,
but get someone to write that forward. And for me, that would really focus on the benefits of general practice. Maybe Jeremy Hunt will write this for us. Who knows?
who knows?
But
Yeah,
the continuity, the cost effectiveness, that gatekeeping that protects the whole resources of the NHS. How health systems with effective general practice, have better equity of outcomes, and better outcomes compared to other health services that don't have that similar emphasis. I think there's a lot that could be put in a really optimistic kind of opening forward and setting the
mhm,
scene, just to because you've got to kind of sell this to people. It can't all be negative. I think there has to be
mhm.
some positivity there. So that's how I'd kick things off. Um, Anything else you would include? It's setting the scene. I suppose you have to set some of the jeopardy there, what people might lose, and that the system is under pressure and needs change. But anything in particular?
No, I think, recognizing health inequalities is always an important part, and we've seen a massive spotlight on that post-COVID and stuff. But actually understanding what people actually want from their healthcare service, versus what people think they want, I think is an important part to potentially counterpoint and stuff, and that's potentially where some of the stuff I know you're talking about will hopefully lead to.
Hmm. I guess so. What you're saying is know your stakeholders, the
Mm,
audience. So the government's going to read this. It's got to hit notes for them. Obviously
mhm,
the general population will read it. The media will read it. We've been beginning to learn this last year that these
yeah,
kind of statements and documents are not just written for one audience.
no,
They can be read in different ways by multiple different people. So we have to hit those notes with the keyword. Um, I think just break it down broadly into sections. I think there's probably something to be said for organizational models, evidence-based approach to health policy, defining the activities and scope of general practice, talking about funding and there's a lot
Mhm.
of ways to cut that. Talking about workload and sustainability, and talking about, there's probably some other considerations like environmental sustainability, and so
Absolutely.
forth. So that's how I'd break it down. And in terms of starting, I guess, with organizational models, for me, um, I think that there's an exploration of the different models that are there. There's looking at the partnership model. Is that the right model going forwards? Are there alternatives? Will we have a blended system? What's the role for primary care networks? Oh gosh, federations, or should the focus be the tried and tested individual unit of general practice that is the practice? Um, there's lots of possibilities, isn't there? And this is where
Mhm.
we're brainstorming, and we need people to help us with ideas about
Yep.
what's best, what actually should we suggest. But probably we outline the possibilities as part of this section as well. Yeah, any thoughts about tackling that organizational model theme, Gandhi, in a
Well, I
paper?
think we're going to be living in a new organisational model of the NHS. So, the Tories told us there wouldn't be a reorganisation of healthcare, and actually, we're about to have one of the biggest health reorganisations itself, as CCGs transmute into ICSs, and ICSs then sit above ICPs or Bs, and then you've got the PCNs, and then the practices and stuff. So, if you want to find out more about that, check out our Building Back Better Practice or something like that. I can't remember what we called it, but there was an episode we did with building blocks and Lego and stuff, and that's a really good one to explain the different units of healthcare that's now existing in primary care and communities and stuff. But understanding that system and what that means moving forward is going to be really interesting. And I think adapting to that, many places are now seeing the PCN as the unit of healthcare delivery rather than it necessarily being the practice. And is that correct? Is that appropriate? Is that sensible? Is that sustainable? We need to know. What do you
Mhm.
think? Let us know.
But it is happening,
It is
in my
happening.
opinion.
Mhm.
Yeah, yeah, and it's a big shift, and it's without the consent of the profession as well, or there really
Absolutely.
being an actual open debate about that
Mhm.
that being the thing that is happening. But that seems to be the thrust of NHS England.
Mhm.
Yeah, another area. Speaking of organisational change and changes in general, made by politicians without often full engagement or evaluation, sometimes, I'd really like to see something about an evidence-based approach to health policy. The NHS and general practice has for too long been the football of the media and
Yep.
politicians, um, and uh, and there's a lot of misinformation, out there, and playing with figures, numbers of GPs, numbers of appointments, workload, demand. Lots of things are used quite carelessly by important people, I think. And I'd love to see something like, we have the Office of Budget Responsibility, for example, who
Mhm.
give an independent opinion of economic policy for the country. If the Chancellor proposes a change in taxation, what do they think will be the impact on output,
Mhm.
productivity, and so forth? And that's a funded body that is independent, that gives a trusted, independent opinion on something as important as economic policy. And I think health policy is also important.
Mhm.
So I'd love to see something else which holds the things that politicians say about health statistics and policy to account. I'd love to see
Mhm.
that. Sorry, I get off my soapbox in a
No, I
second.
I agree. I think there's an element of that with organisations like the King's Fund and that kind of stuff, that they do some of that work, and they are technically impartial. But I understand where you're also coming from, something that's completely independent, to remove this whole concept of healthcare policy announcements and stuff, and how they're amazingly awesome. And actually, when you look at the detail, it shows how potentially even damaging they could be to the longer term health of the population and stuff. So I think, yeah, having a
Yeah,
organisation to understand and analyze that information. I mean, to be honest, we've been doing that for general practice, haven't we, Andy? That's
yeah,
kind of what we do.
give us the official the official
Yeah, give us
title.
the title, give us the funding that comes with it. Yay, that'd be awesome.
The Office for NHS Responsibility, something
Yeah.
like that. I mean, the King's Fund does really great work, but the King's Fund might say one thing, and then the Adam Smith Institute might say the other thing, something else. Whereas I think a body which has objectivity baked in, and I'm sure the King's Fund does does try to be
Mm.
objective, but that can be seen by everybody as objective would be really, really helpful. And that the politicians have to listen to. I think that's part of
Yep.
it, that they have to listen to and cannot, really dispute the findings,
Weasel
or the
their way
stats.
out of it, yeah.
Yeah,
Mm.
yeah, that provide the official statistics that the government use, if you know what I mean. They
Mhm.
can't just pick and choose. So I think that'd be really, really important. I think there's a theme or a section about the activities and scope of general practice. That was a large part of the document that you produced with John Cosgrove in 2015.
Mhm.
And I think there's a lot of debate to have there, isn't there, about whether we place some things in scope for general practice, whether we place some things out of scope, whether we say that certain things or aspects, we
Mhm.
no longer deal with because we are focusing on other areas that better suit our skills,
Mhm.
um, or not, but I
Mhm.
think that's a big theme. I'd really love to know what people think should be in or out of scope. I think that'd be quite a lively discussion.
Mm.
And then I think there's a big talk about funding, really. You touched on funding in yours, hadn't you? Or not only touched on it, but you'd called for more and
Yeah.
proper funding um, in there, and also changed the funding model as well. And I think those kind of debates need to be there in a new blueprint going forwards, essentially. And there's all sorts of questions, isn't there, to ask about funding? Is it capitation? Is it activity? Um, are we pooling funding with other organizations, social care,
Mhm.
secondary care, so that potentially more money might be focused on community services or
Mhm.
prevention, leading to downstream savings in other parts of the health care system? Are we getting on board with that sort of thinking?
Mhm.
Um,
Are we moving
I
towards
guess,
true vertical integration, which is what the ICSs are meant to be trying to deliver? Be interesting to see whether they could do that in the future. Um,
yeah,
yeah, that'd be really interesting.
yeah, yeah. Is that part of the new blueprint or not?
Mhm.
And then also, I mean, you'd put on the table essentially privatizing general practice was essentially what you were saying
Mhm.
at the end in idea 7, and is that something that's still on the table? I'd be really interested to know what people think out there about whether we, whether that's an option to privatize general practice or partially privatize some sections of it. But there's going to be a section on funding, I think, in this blueprint, so we need to decide what's in it.
Absolutely.
Um, yeah, and then another theme area I think would be workload and sustainability. The BMA's guidance for safe working in general practice that we've reviewed a few weeks ago
Mhm.
was an interesting document. I think sometimes it strengthens your blueprint if you incorporate things from elsewhere. You can gain allies because they
Mhm.
might support your ideas, and you're drawing from a place where they've already done the thought work. But there's probably conversations to be had about appointment length of the working day, amount of
Mhm.
patient contacts within the working day, and so it feels like that probably ought to be in a blueprint for general practice. Similarly, how much people get paid and the remuneration for the profession. I think, given that we've spoken about GPs having a large real term pay cut over the last sort of 10, 15 years,
Yep.
that needs to be in there as well. So maybe something about workload planning, training length. Gosh, reading off a bit of a wish list here, aren't I?
Absolutely. But that's what we're creating, isn't it, Andy? We're creating effectively what we feel to be the future of general practice in order to continue its sustainability, deliverability, and basically managing the health of our local population. And I think one of the things we're really keen to hear from is yourselves, our audience, our listeners, people interested in this area, to understand what you think about this and how can we incorporate those elements into a new blueprint for general practice.
Mm.
So let us
And
know.
then, yeah, and I suppose finally, there might be other themes and other considerations which people out there think are really, really vital and important. I mean, we've not even talked about things like environmental sustainability or diversity and
Mhm.
representation and so forth. But those things are important, and
Absolutely.
I'd be interested to know what people feel a blueprint should say about those sorts of issues. And I'm sure there's issues that we've not even thought to include in this video that are really, really
Mhm.
important as well. So my hope is that in this episode, people have had fun looking at your blueprint from
Mhm.
2015, and that maybe we've started people thinking about what should be in the blueprint going forwards, and also a bit
Mhm.
on how to make that saleable. to the government and other stakeholders that aren't from within our own profession.
Mhm.
And hopefully people are enthused enough to contribute
Mhm.
and
And if you
give
do,
us some ideas and thoughts.
absolutely. And if you do, let us know in the comments below. Reach out to us. The best way we're going to recommend doing that, and for all future stuff as well, is go to speakpipe.com. So that's speakpipe.com/egplearning. And again, the G and the P are capital. The rest is all lowercase. Click the start record. It will then use the microphone in your phone, or if you're on a computer, and the webcam or whatever, and then you will be able to send us a brief message and we will get that and we can respond to it as well. So do let us know. Clearly, if there's weird stuff coming through that, we're not going to share that on the podcast, but we may share stuff if you do send it to us. So do feel free to use it and we will check with you if you're happy for us to use it as well before we do so on air and stuff. But absolutely contact us, let us know what you think. We would love to hear from all of you. And yeah, we will hopefully start the moves to creating a new blueprint for general practice. How awesome would that be, Andy?
That would be absolutely fantastic. And even better, if Jeremy Hunt, if you're out there, you can write the foreword for us. It'd be absolutely great.
Absolutely. So as usual, eGPlearners, let us know, contact us, let us know what you're thinking and stuff. And we are here to help tech enhance your primary care and learning. We'll catch you in the next episode.